Hi, it's Dr. Centeno, and today we're just going to get some questions answered. I've had some questions pre-submitted. I'm still out and won't be back in the office for about 10 days or so, but I know that the questions sort of build up over time. So my goal here is just to sort of continue to answer some questions, make sure people are getting the solutions they're looking for, and also just to make sure that I'm out there trying, even though I'm on a different time zone, to just to answer questions and be available. So these are all pre-submitted questions. Now I realize I'm broadcasting this live, but I'm broadcasting it at a time which is not going to work for most Americans. Now, there may be some Europeans online that want to ask some live questions. So if you're online and you want to ask some live questions, then feel free to do so, and I'll try to throw those in with some of the pre-recorded questions. So we'll get started with the pre-recorded questions first. First question, will posterior PRP help with atlas and transverse ligament damage? You kindly recommended this to me since I'm pregnant, unable to get the PICL currently. In the past, prolotherapy did more harm than good, so wondering the difference. It's a good question. Realize that the transverse ligament is internal. So there's no way to get to the transverse ligament via posterior injections. Now, what you can do is tighten down the nuchal ligament, the supraspinous, interspinous ligaments in the back here, and hopefully that's enough to provide some stability, which is what I think was being recommended. Having said that, if prolotherapy didn't seem to work, then it's unlikely that PRP is going to work. So you may want to wait until after you deliver and just get the transverse ligament injected directly, which would be the PICL procedure. Next question from Ash. Hi, Dr. Centeno, with unilateral rupture of Ayler ligament, is that something that may be treated with PICL procedure? I have sent through my information for telemedicine, just awaiting confirmation as I wanted a second set of opinion with all my imaging. Thank you, Ash, Sydney, Australia. You know, Ash, I don't think I've ever seen a unilateral rupture of the Ayler ligament. So realize that when you use the term rupture, what that means to me and many physicians is a complete retracted tear. So what that would mean is rather than the fibers just being damaged, which is 99.9% of these injuries, the fibers are pulled back and snapped back like a rubber band. So, or like cutting a rubber band. So I doubt you have a, quote, rupture of the Alar ligament. You probably have some damage to the Alar ligament, but probably not a rupture, because a rupture would be a 1 in 1,000 CCI case. So assuming it's not a rupture, yes, PICL should work just fine with about a 70% success rate. Happy to look at your images to see, obviously, if it is a rupture. Realize to be able to see the Alar ligament, we would need a specialized 3 Tesla MRI with a head coil. And Carla in my office has that information to get that type of imaging done. But it's a very specialized MRI. It's not going to show up on on an open MRI, just because an open MRI doesn't have the oomph behind it to be able to image the Alar ligament well. It'd be a closed bore 3 Tesla MRI with a head coil and a very specialized imaging technique to be able to see that. Next question from Francis. Do you define PRP grade solely in terms of concentration of platelets or aim to deploy an absolute number of them? Recent blood test result for platelets was 120. Is this bad, and will it compromise my PRP outcome? You know, Francis, our focus is on a concentration factor. So what that means is if it's, let's say, 10x PRP, then that's 10 times more concentrated than what you started with. Now you've got a lower platelet count. So obviously you want to figure that out, make sure there's no particular issues causing that low platelet count. You may want to get it repeated because sometimes that bounces around a little bit. But when it comes to looking at the concentration of platelets, we would just further increase your concentration, knowing that you have a lower count. So for example, if we're going to use 7x or 7 times your normal baseline, and we know your baseline is a little low, then we would use 10x to compensate. So it shouldn't be an issue, but certainly figure out if that's real, number one, and number two, if there's a cause. Next question, Lillian. Will stem cell therapy give around 90% recovery on hip arthroses, even if there's impoundments? I think what you meant was hip arthritis with impingement. I don't know where the 90% recovery number comes from. That sounds like someone who has not been collecting any real outcome data. That sounds like I made that up number. So if someone's telling you there's a 90% success rate, then that's probably fiction. Now with mild hip arthritis and impingement, there's a high success rate. But once you get to moderate or severe hip arthritis, then there's a lower success rate. And so just be careful there. So again, mild hip arthritis, good results. Moderate, severe hip arthritis, less likely to recover. Also realize that that's very different for the hip than for things like the knee. The knee, much higher success rate with severe arthritis than for the hip. And so just be careful there, because the 90% number sounds like I made this up number and not actual data. At regenexx, we collect actual data on this. And it all depends on the severity for hip arthritis. Dan, can you please provide a summary reminder of the various recent advancements in the Picl procedure? A, dual arm fluoroscope and its advantages. Yeah, so I think what Dan is bringing up is that we've done a lot of things to continually advance how we do the Picl procedure and make it better. Probably the biggest change that we've seen most recently is the advent of dual access C-arms. What that means is we've got one X-ray beam going this way, and rather than just turning the beam back and forth, back and forth, back and forth, front side, we actually now have two X-ray beams working at the same time, one from the front, one from the side. And what that allows us to do is to be much more accurate with placement. So it's dramatically improved hitting certain structures that we're trying to inject. So that's probably been the single biggest recent improvement. And we just made that improvement. Oh, I want to say that was back in May when we added that. So it's only been for about 5 months, but it's made a tremendous difference. And then B, evolution of the injection technique. Yeah, so I think what Dan's talking about there is we now more routinely go above and below the atlas. And that allows us to hit different parts of structures. So for example, if we go below the atlas, we're going to end up hitting in most patients just the lower portion of the Alar ligament. But if we go above the atlas, we'll get the upper sling portion of the Alar ligament. Now, in some people, you get flow from below all the way to the very top of the Alar ligament. So everyone's different there. But again, by going above the atlas, which is something we've been doing more routinely this last 18 months, we can inject some additional parts of the ligaments. C, improvements in patient intake forms and office procedures processes. Yeah, that's a continual one. So we've been collecting much more data over this last 18 months or so. In addition to that, we've been refining in office procedures processes. For instance, having discussions with patients who are taking low-dose naltrexone or THC and how that might change their anesthesia requirements. Trying to identify patients up front who might really struggle in tolerating doing more sites versus fewer sites, those sorts of things. And then D, any other advancement in the works. Dan, we're constantly looking at ways to improve this. My guess is we'll see in the next 6 months some changes in the mouthpiece design again. We've done that about 6 or 7 times so far, just to further refine things. The good news is I think the Picl procedure is 90% dialed in, or 95% dialed in, and the changes coming forward are going to be small and iterative as we encounter certain challenges to solve. Daniel, is there a difference in symptoms from CCI atlas skull instability and AAI atlas axis instability, or the symptoms equal? Daniel, I don't see a huge difference in the symptoms between the specific areas that are unstable, C0, C1, or C1, C2. Second question from Daniel, why can't ligaments heal on their own over time? Daniel, the vast majority of ligaments do heal on their own over time. When we see a patient, though, for treatment, we're seeing someone whose ligaments didn't heal. So just realize we're seeing a selected subset of patients who couldn't heal. Now, why wouldn't ligaments always heal? A lot of it has to do with the amount of damage, the age and reparative process of the patient, and then just the location within the ligament. Some ligaments are better vascularized than others. So, for example, we know the ACL ligament in the knee doesn't heal well, whereas the MCL almost always heals, and that's in the same knee. So those are the kind of things that control that healing. Number 3, do you have any new data to share from the clinical trial on the outcomes? No, I think I've shared the last data not too long ago. I think it was the last video or the video before that, where we were looking at whether or not hypermobile EDS or HEDS had any bearing on outcomes, and it didn't. Then Daniel, fourth question, my head feels like it wants to fall backwards. Which ligaments are responsible for extension? Daniel, the ligaments you may want to look at would be the anterior longitudinal ligament up front, and then some of the front ligaments between the atlas and the skull. If you go to the book, you'll see ligaments there like the SAAOL and the AAOM. Those are ligaments to focus on there. Alexandra, when coming for PICL treatment from Europe, is a special visa required or normal tourist visa because it's medical tourism? Alexandra, as far as I know, it's just a standard tourist visa. I don't think there's anything special. Now, obviously, you may want to check with your specific country because some countries may be different. But if you're coming from most of Europe, it's just a regular old trip across the pond, just as if you were coming as a tourist. Debbie, how crucial to healing are the clock exercises? Yeah, Debbie, it's not really healing. Realize that there's 2 components to instability. One is that the ligament is damaged. The other is that the muscles are atrophied, meaning the muscles are smaller and not working correctly to stabilize. So you're not really healing any ligaments with the clock exercises. You're building and trying to get the muscles stronger, because stability is, again, ligaments, muscles, ligaments, muscles. So if we tighten the ligaments, eventually the muscles have to be strengthened, and that's what the clock exercises do. And then second question for Debbie, are you training more doctors in the PICL procedure? Not at this time, Debbie. That's going to be a while before we get to that point. So no, not at this time. The only place that the PICL procedure is, and for the foreseeable future will be available, is in Colorado at the Centeno-Schultz Clinic. Diana, how does low CXA impact the upper facet injections or the PICL outcomes? Diana, I haven't seen any effect of low CXA so far on either of those. Then second question from Diana. With low CXA and low-lying cerebellar tonsils, is the inflammation from the injections going to cause more compression on the brain stem? I don't see that. I think you might be talking instead about a situation where the dens goes backwards and there's a large pannus there, and there's some contact between the pannus and the cord. We don't have any data that shows that, but my personal belief is that there's a lot of contact there, cervical medullary syndrome, then the swelling in that area from any procedure done in that area may be problematic for the patient, but neither of those have anything to do with a low-lying cerebellar tonsils or CXA. 3, can you show us what KRI0 versus 1 looks like on an MRI image? You know, I don't want to mess this one up here. I apologize, just because I'm broadcasting from Europe. I don't want to get too fancy today. But suffice it to say, and it's important to realize, that both KRI0 and 1 are normal variants. And again, I can't stress that enough. And that is that there's a lot of people walking around without any symptoms out there that have a KRI0 and 1. So what KRI0 means is the brainstem just touches the line that goes across the foramen magnum. That's an artificial line that doesn't exist. It's a line that's drawn. And a 1 allows for 5 millimeters of descent beyond that line, that artificial line drawn across the hole in the bottom of the skull. But be careful with that, because just because that's seen on imaging doesn't mean it's symptomatic at all. There's a lot of people walking around out there with KRI0 and KRI1 who don't know about it. They've got no symptoms from it at all. So the current belief is that it's actually KRI0 or 1 plus instability that produces symptoms, and that KRI0 and KRI1 by themselves produce no symptoms. So just be careful with that terminology. Number 4, I'm unable to nod. Yes, my head takes little detours to get into flexion. Feels like the joint is watery and out of place, but supine MRI is normal. I used to do clock exercises, but now my head detours. Can I keep going, or is it dangerous if I don't know exactly what is happening? I'm going to an A who thinks the CSF is causing turbulence and flow issues. Listen, if the clock exercises seem to help, you can certainly continue to do those. It sounds like you would do well to get a, at the very least, a digital motion X-ray or DMX, and if that's not possible, a movement-based MRI would be helpful to see if there is some additional motion at 0-1, because that 0-1 is what would control that nodding motion. Number 5, from Diana, will posterior prolotherapy help forward slippage of my C4? Yes, that can help. We published a paper on that, almost 20 years ago now, showing that posterior prolotherapy did help forward slippage, or what we call anterolisthesis, in those lower cervical vertebrae like C4-5. Next question, Sam. X-ray shows some sort of calcification between the skull and between C1 and C2. Does this exclude from treatment? For context, symptoms are extreme: head heaviness, burning, neck pain, brain fog, and face pressure. Not usually, Sam. I think you're talking about some osteophytes or bone spurs up front, which are not uncommon in CCI patients. But we do need to look at those to make sure that they're not blocking any access from where we would get to the ligaments from the front. Manuela, is it normal to develop extreme TMJ a week after PICL number 2? Didn't happen with PICL number 1. No, meaning what you may be experiencing there, though, is just a change in the way things are moving around due to the inflammation, meaning TMJ is a common thing in patients with craniocervical instability. About 1 in 5 of our patients have TMJ. And it's due to the fact that the jaw and the anterior musculature is trying to stabilize the head on the neck. So my guess is it's probably just inflammation and things moving around, and it will return to what it normally is once the inflammation goes away, which is usually around week 2. Liam, number 1, are the Alar ligaments responsible for forward and back stability as well as lateral stability? My CCI feels like it's equivalent across 360 degrees. They are responsible for some forward and back stability because in most patients, not everyone, they tend to go backwards a little bit. So yes, they do have that function as well. But the transverse ligament would control more of that. Number 2, from Liam. Other than customizing the injection sites, is the PICL procedure able to be made more conservative, less invasive? Certainly, we do that all the time, Liam. So what that means to us is that we would reduce the number of injection sites because some patients can't tolerate more than 1 or 2 injection sites. So we can make it more or less invasive depending on the patient we're working with. Daniel, do stem cells migrate at all? Can stem cells injected in the lower alar ligaments migrate to the upper alar ligaments and vice versa? Can they migrate to nearby ligaments? Daniel, they generally don't migrate to nearby ligaments. They generally stay where they're put in a ligament. Realize the ligament is sort of fibrous and they would get trapped in there. Now, they generally can migrate throughout the length of a ligament, but how far, nobody really knows at this point. But I think it's reasonable to assume that they migrate throughout the length of a ligament because those pathways exist. But jumping from one ligament to another, no, that's likely not going to happen. Patty, is it safe to do prolotherapy or PRP for CCI if you have tethered cord? Patty, let's first break that into occult tethered cord, which is an extremely controversial diagnosis that 99.9% of neurosurgeons do not believe exists, and an actual tethered cord. So an actual tethered cord is where on MRI we can see a tumor or scarring or a prior surgery pulling the cord down below where it normally terminates. So for instance, it normally terminates around T12 and the spinal cord is pulled down to L3. And that's something that all neurosurgeons would recognize exists. Then we're talking about occult tethered cord, and that's something that 99.9% of neurosurgeons do not believe exists at all. And that is this concept that there's some pressure pulling downwards on the cord that really can't be seen on MRI or can't reliably be seen on MRI. And then a constellation of symptoms that are kind of vague, things like problems with urination, which can also be caused by low back pain, etc. So just be careful there with that terminology. As far as the occult tethered cord, which is the type I believe you're talking about, and that's the controversial one that most physicians believe doesn't exist. Prolotherapy or PRP, no, are not going to have any impact on that. Leah, what is the cause of people not improving at all with multiple PICL procedures? Do those people benefit from PRP? Leah, yeah, this procedure, like all procedures, has a success and failure rate. So for instance, all surgeries have success and failure rates, and this procedure does as well. So about 30% of our patients are not going to improve with multiple PICL procedures. About 70% will. What's the cause of that? There could be multiple causes. One of the causes could be that the neurologic damage is baked in and it's not going to change regardless of whether or not you can improve the stability. Another would be that the ligament damage is too much and we're not able to heal it. Kevin, number 1, could CCI cause scoliosis or scoliosis cause CCI? Are they both symptoms of something systemic, i.e. heavy metal toxicity? Kevin, neither of them would be symptoms of something systemic like heavy metal toxicity. So neither would be related to heavy metal toxicity. And CCI could theoretically cause some scoliosis, but more likely it's scoliosis meaning a side bend of the spine, putting differential forces in the upper neck, leading to CCI type symptoms. So it's usually, in our experience, scoliosis making CCI worse or CCI symptoms worse, rather than CCI causing scoliosis, and neither, in my opinion, really having anything to do with heavy metal toxicity. Kevin, number 2 question, thoughts on peptides like BPC-157. Kevin, the research on BPC-157, if you go to regenexx with 2x's.com and my blog and type in BPC-157, shows that in experimental studies, it works about as well as PRP. There's no magic. In addition, I wouldn't trust that you can buy BPC-157 right now and that you can ingest it or inject it and have it work, because there's no control over the manufacture of any of that right now. It's all in the scary world of online social media promoted sales. So I wouldn't trust any site to be able to sell me BPC-157 right now. It's not FDA regulated. And my guess is that few of those sites actually produce anything that would assay out as pure BPC-157. And we've tested that with other things before, where we've tested these things in the lab. For instance, transforming growth factor beta was a big thing 5 or 6 years ago. It was being sold online. We tested it in our lab, and there was no transforming growth factor beta in the vial. So I would be very, very careful with all that stuff right now. Kevin, 3, thoughts on IV therapy with NAD, vitamins, or amino acids. I don't think it's going to hurt. I don't think it's going to help, but I don't think it's going to hurt. 4, thoughts on insulin resistance effects on ligaments. Kevin, now I think you've hit on something which is much, much more accepted, and we've got much more data about, and that is insulin resistance or pre-diabetes wreaks havoc on the body in general. It's hurting arteries, it's hurting ligaments, it's hurting tendons, it's hurting the cartilage, etc. So get your insulin resistance cleaned up to the extent that you are able prior to really doing anything, or concomitantly with getting those areas treated, because that's one we have a lot of data on, showing that insulin resistance or pre-diabetes, also called metabolic syndrome, wreaks havoc on the entire body, not just ligaments. Ruthie, is there less chance of success with PICL if the patient can barely hold their head up without a neck brace? Ruthie, I always tell patients that that's the depth of the hole. And what I mean by that is that, things like years and years of dependence on a neck brace will make the muscles extremely weak. And by making the muscles extremely weak, it's going to take a long time to get those muscles stronger again. So that hole has been dug deeper, and it takes more to fill that deep hole. So I don't know if it affects the ultimate chance of success, but it certainly means a protracted recovery, because those muscles are going to have to be strengthened again. And if you become completely dependent on a collar for years and years, then that's a multi-year process of getting those muscles stronger again. Stacy, any suggestions on how to cull through the myriad of physical therapists to find one who truly understands C-spine injuries, won't undermine regenexx injections? Is there a specific type of therapist protocol should be focusing on or avoiding for that matter? Stacy, this is a really great question, because 99% of physical therapists aren't going to have any idea of what to do here. And obviously, there are local physical therapy experts in several communities who we would recommend, because we know they understand this stuff. Having said that, if you were just trying to place a bet based on qualifications on someone who would be more likely to understand what's going on, I would go with an IPA physical therapist. So if you just look up online, IPA, just like the beer, IPA physical therapist, there is a national certification group and testing and training that they have to go through. So they're trained to an extremely high level. So I would start there. And I think if you had to place a bet that IPA physical therapist is going to know which end is up, your bet would be right 90% of the time. Next question, Edward, could you clarify what your clinical experience has been with respect to healing timeline for PICL by age? There's a lot of conflicting info and anecdotal experiences on the internet. Yeah, Edward, I always say that social media is a two-edged sword, right? It can be incredibly helpful in certain circumstances where you're trying to rely on someone's direct experience. So, for instance, I'm on a sailing trip right now, and sometimes it's difficult to find a docking berth because of the specifics of the boat. And some marinas are too small, other marinas that are too big, don't want to deal with it. So social media has been very helpful in getting out there and asking people, hey, what's your experience with XYZ Marina? Is that a good fit? Where social media tends to fail is with stuff like you're asking. So for instance, the particular boat that we have, there's 3 or 4 instances of the rudders falling off. That's out of thousands and thousands of produced boats, right? But those 3 or 4 instances, those people are pretty pissed off. They're very loud. And so you would think that the rudders are falling off all of these boats. Obviously, that's not the case. So same thing here. As far as age is concerned, we haven't seen a huge difference there, but I will say that young people tend to heal more quickly. So if you're younger, you certainly have an advantage. If you're older, I wouldn't be too concerned. And again, I always say be careful with social media because the loudest few people who've experienced something that's atypical tend to dominate the conversation and really skew the perception of different things. So use social media for where it's really good, which is trying to gain a little bit of experience in scenarios where you're out in the middle of nowhere and you don't really know what that is over there. But not so good when it comes to loud people shouting a very unique experience that's not common. Phil, next question. In the same way that your clinical data shows PICL helps EDS patients with CCI just as much as trauma-induced CCI, do you also have clinical data showing the same is true for posterior cervical PRP bone marrow injections? I'm not quite sure what the question is. I think you're asking is whether or not PRP versus bone marrow posteriorly has a different outcome. I don't see that it has a different outcome in most patients. I think posterior PRP is going to do as well as bone marrow injections for most patients relative to bone marrow. If that's the question, I'm pretty sure it was, but maybe not. Megan, what's the best way to get a hold of your office to schedule a consult with you? Is the first consult still virtual? I'm in California. Yeah, Megan, we do a telemedicine for that first consult just to make sure that things are a good fit before you come all the way out here to Colorado. So best way to do that, listen, a good way to do it is to get in touch with Carla, my assistant. The normal way to do is to go through the call center, but if you want to sort of bypass all of that, then just reach out to Carla directly. Her email I've put in here a couple times is ksalas, K-S-A-L-A-S, so ksalas at Centeno-Schultz.com, Centeno-Schultz.com. So ksalas at Centeno-Schultz.com gets you to my assistant. Fatjan, in my flexion extension x-ray, assuming it was done correctly, though my chin didn't touch the chest during flexion, all CCI static parameters seem to be within range, but translational BAI and BDI were measured as 3.4, 2.9, 2 is borderline, I think. With all my other symptoms, why isn't it still enough to confirm instability? But it was suggested to do MRI, CT with flexion extension. Well, flexion extension x-rays have their limitations. So my guess is that's probably why we don't use BAI and BDI to determine instability. I know some of the neurosurgeons like those measurements, but we don't use those measurements. And as I always say, if we had to line these imaging studies up for us and the likelihood of getting to a CCI diagnosis, if it's present, it would be DMX first, flexion extension MRI second, and traditional supine MRI third. So again, flexion extension x-ray may not show enough for you to really get to that diagnosis. And then Fatjan, is it beneficial to sleep with a soft collar in terms of avoiding movement, promoting better neck muscle nerve relaxation during sleep, if that makes sense? I wouldn't sleep with a soft collar if you can avoid it, Fatchen. My concern again is just creating weakness in the muscles, which then creates a second set of issues and problems. Fatchen, I've heard that we may have to stay away from a collar as much so we avoid more muscle atrophy. That's true. But what's the difference between lying down in bed versus staying upright in a hard collar in terms of neck muscle atrophy? Well, not as much as certainly being upright or moving about. I think lying down will use those muscles less. But there is a certain amount of muscle tone that's maintained when you're sleeping, especially when you're doing things like turning over, etc. So it is going to have an effect, but you're right, not as much as an effect as if you were standing up or moving about. Fatchen, how to know at what level the muscle atrophy is happening? The MRI you showed in one of your previous articles, I can see lots of white at some point in mine. But at which C level is it happening, or happening every C level, C2, 3, etc.? Most common thing in CCI patients would be C2, 3, but sometimes there's atrophy lower down as well. So that's probably a better thing to deal with on telemedicine, and I can show you specifically where the atrophy is. Emily, Algocels UK has stopped treating CCI patients, stating not enough evidence. Any idea why, if this will change anytime soon? Those of us in the UK are stuck. Yeah, I would agree with you, Emily, and I think I've answered this question before, but just realize that that injection of the hypercervical spine, which is what they were doing for a while, 0-1 and 1-2, is rarefied air for 99.99% of experienced interventional spine physicians. So what I mean by that, let's take a big metro area in the United States. Let's say the metro Los Angeles area, right? Millions and millions of people live there, one of the largest metro areas on earth. And if we take that entire area, we would maybe find one doctor within that entire largest metro, one of the largest metro areas on earth, that had injected those two joints, 0-1 and 1-2, more than a dozen or two times in their entire career. In the United States, we'd probably find only about 100 US physicians. So again, most sophisticated healthcare on earth by far in the US, not because of anything other than we waste a lot of money on healthcare here, but it has the effect of producing more super specialists than any other place on earth. So more doctors per capita than any other place on earth. And despite that, there's only 100 US physicians who have injected 0-1 and 1-2 more than a few dozen times in their career. So because of that, if you've only done something that often, you're not going to feel very comfortable with it. And I think that's what was happening with the Algocels UK site. They're a great site. They do wonderful work. I still refer patients to them all the time. But when it comes to injecting these two areas, they didn't have that kind of experience that we have at Centeno-Schultz, meaning we've done these two areas thousands of times. There's no place on earth that's done them even 100 or 200 times. And because of that, we know what the risk benefit looks like in our hands. The risk is extremely low. The benefit in the right patients seems extremely high. Hence, we're comfortable in doing that. But if you don't have that kind of experience, you're not going to be comfortable. So they're not comfortable, and that's all good, because 99.99% of the doctors out there aren't comfortable doing that type of injection. And that's why we try to limit those procedures as much as we can to Centeno-Schultz, because there's no place on earth that's done those places thousands of times as a clinic other than Centeno-Schultz. We do have some other sites in the US where we certainly trust those doctors to do a good job, but they've probably only done it again 50 times in their whole career. Maybe we've got one or two that are approaching 100 times in their whole career. So that's what that's all about. So I apologize for our UK folks, but regrettably that means, again, come to Centeno-Schultz. Diana, next question. Can PICL help increase a low CXA? Dan, I don't know that there's any reason to increase a low CXA. Just realize that all a low CXA means is that the head is rotated forward and we're talking about instability. So a CXA is a static measurement. Instability can only be seen on a moving image. So there's no issue with low CXA other than it could indicate instability, in which case the instability needs to be treated. Diana, can you show us a picture of Chiari0 versus Chiari1? I think I answered that one already. Diana, are people with low cerebellar tonsils having worse PICL outcomes? I don't see that at this time at all. And then Thatchin. In Canada, nobody does posterior PRP above C2. Can PRP and Prolo below C2 help the instability, maybe help with muscle atrophy, or might it make it even worse? Yeah, Thatchin, we just talked about that, and that's great that you just brought that up because, again, there is nobody in Canada that does injections above C2 at 0.1 or 1.2. So think about that. We have a large industrialized first world country which has excellent healthcare, and in the entire country there's no one that has a lot of experience in injecting 0.1 and 1.2. So that just goes back to what we were talking about before. If your problem is C1, C2, and 0.2, then injections below that aren't usually going to help. Thatchin, how to know at what level of muscle atrophy? Okay, so I answered that one already. And then another from Thatchin, I see fainting as one of the symptoms reported of CCI, not common though. Since I started experiencing it too, one time while turning my head fully to the left, also getting up from bed, feeling it spinning around on top of my head. Why does it happen though? Is a relationship between CCI and Bowhunter syndrome? You know, the fainting I think is not really vascular compression of the vertebral artery, which is something that would happen in Bowhunter syndrome. But I think the fainting is more likely related to a low heart rate or a too fast a heart rate that can sometimes happen due to irritation of the vagus nerve. So I don't think that that's related usually to Bowhunter syndrome, but obviously we would look at that. So those are my pre-submitted questions, and I see I got a bunch from our folks in Europe, so I'm going to answer those as well. Farouk, can a stretched sprained ACL ligament hurt? Only sprain, no tear on MRI? Certainly, a stretched or sprained ACL ligament can produce instability, which can then cause knee pain. Alex, are there benefits from intravenously injecting stem cells even with the pulmonary first pass effect? No, there's no proven benefits at this point in the types of conditions we treat to an IV injections of stem cells. I think if you're seeing that because it's a high profit margin procedure for the clinic, meaning that you can hire a medical assistant for $20 an hour to start an IV versus a physician that would demand $400,000 US a year to have the experience level to place these cells in the right spot in the musculoskeletal system. So no, I think you're just seeing a business model, not something that's medically real. Elvis, hi Chris, how long after PICL treatment stay that healing effect on ligaments, joints? So far, I think when we've healed these ligaments, that's been a more permanent effect. But realize we've only been doing PICL treatments for about the last 7 years, I think. So I've only got 7 years of experience there, but we've got many more years of experience, 20 plus with healing ligaments. Ash, hi, Dr. Sorry, I tuned in 5 minutes after the video. I may have missed the answer to my question. However, the same patient originally from overseas, depending on the severity of ligament damage. My neuro believes I've ruptured the Alar ligament on the right side. Currently in a brace, worried about likely me needing fusion. Yeah, so Ash, why don't you reach out to me via email, because I'm always certainly happy to put in the extra time and effort if someone's really struggling. So I'm going to put the email address that goes to my desk here in the comments. So I'm just typing that in now, Ash. So Centeno office at centeno-schultz.com goes directly to my desk. I'm also going to put my assistant's email address in there, and she can also help as well. But once you reach out, and I'll try to take a look at what you have to try to see what's happening there, whether or not that's accurate. RR Animal Rescue, Texas High, was on omeprazole, 800 milligrams, day 2 doses, 4 years, per GI doc after ER, repair of ruptured ulcer in my small intestine, my bones now breaking many places, type of calcium. Not sure what to do with that question. Venkata, what is the success rate with hip replacement? I would say that well, actually, that's a great question. If you go to the regenexx blog, it's regenexx.com, and you type in hip replacement outcomes, what you'll see is I think about 6 out of 10 patients are satisfied with their hip replacements, and about 4 out of 10 patients or so still have substantial pain after hip replacement. So that's the last data I've seen. Venkata, does during the surgery core compression at the hip can be depressurized? Not sure what that question means. Okay, well, guys, thanks so much for watching, those of you that are live in Europe. And for those of you that will be watching this in the morning in the States, good morning. Hopefully I got to all of your questions, and have a great day. I'm still out for about another 10 days, and then I'll be back. And at that point, I'll be going back to doing my twice a week Facebook Lives. I'm just trying to do a little bit of Facebook Live work here on European time, and to try and answer some of those burning questions that are out there. So thanks so much, and have a great day.